Hi guys, we're just going to go over a psychopharmacology overview, and I feel like this kind of ties some things together, just kind of like another way to look at our psychopharmacology. So I've broken things down into why we're using this drug and the negative potential side effects, and then some really bad side effects that we could have, or adverse events that we could have with these medications here. First of all, I'd like to apologize that I didn't add this to your last slide for your anxiety lecture, and I should have, but I'm just going to add it here. So we're going to talk a little bit about anxiolytics, which is used to treat, should be used to treat our acute anxiety events. Having said that, there's quite a few people that are on long-term anxiolytics. These are benzodiazepines, right? Like our lorazepam or alprazolam, those medications. And the reason why they're not really great for long-term is that we build up that tolerance. If you guys can think of that little dependence chart back from your substance use disorder lecture, how quickly we kind of gain this tolerance, and then we either need to increase the medication dosage or frequency, or the patient will just kind of need the medication to return to a normal state, basically. And this happens within about 6 weeks for our anxiolytics, as the studies have shown. So we try not to give those long term. Build up a quick dependence to these guys, and getting off of them can be kind of severe. It can cause some seizure activity and even death. So we use anxiolytics with caution. Our antidepressants are used especially very well for like our generalized anxiety disorders, and there's some that are kind of more approved than others. I don't need you guys to know those ones, but mostly they're in the SSRI department, that works quite readily for our anxiety disorder. Antihypertensive, so the medications that end with lol are beta blockers, metoprolol, and especially a drug called propranolol are used to decrease contractility, right? So ultimately make a patient bradycardic or kind of lower their heart rate. And this is their body tricking their mind into thinking that they are not in that state of hyper awareness or hypervigilance, or that sympathetic response can really kind of not occur when we have this lack of tachycardia. So it's sort of our physiology tricking our hypothalamus into thinking that everything's just cool. So they use propranolol quite a bit. And then for obsessive compulsive disorder, they use tricyclic antidepressant called clomipramine quite readily too. That's kind of has found to be especially helpful for the patient with obsessive compulsive disorder. Oftentimes in the hospital you'll see a drug used, and also our inpatient psych setting, called hydralazine, and or Vistaril. You'll also see it. Hydralazine, I didn't mean to say hydralazine, hydroxyzine, excuse me. And this Vistaril is initially started off by helping with itch. That's what they designed the drug for, and found out that it worked really good in the case of our anxiety, especially like within the hospital, our acute stuff. So that's not to say people don't go on this long term, but yeah, you'll see that quite frequently used, so don't be surprised if you see that. And that's just used to kind of chill a person out a little bit more. So our antipsychotics here, we have our first generation, or our typical. These are the ones that were first introduced, right? And they include our Haldol, our flufenazine, our thioridazine, and our clomeprazine. And based on how I'm saying these, we don't use the second and third very often, but we do use Haldol and the chlorpromazine, with a fair amount of frequency still. And they tend to work really well for those positive symptoms. I'll go over those in the next slide. And then our second generation or atypical medication, antipsychotics, they're just coming out with new ones all the time, but here's a list of some of them right now. We have our risperidone, our ziprasidone, our aripiprazole, our quetiapine, our olanzapine, and our clozapine. And our typical drugs, our typical antipsychotics, are going to work only on that dopamine level. They do have lots of side effects that we should be aware of, and like I said, they work really well on the positive symptoms. Our atypical is going to work both on the dopamine and serotonin level by blocking. They may work better for symptoms, positive and negative symptoms. So you can see why we like these drugs a lot better. And then a little note that injectables may increase compliance. So our long-acting injectables, they can give shots for intramuscular injections at an arranged office, or medication nurse out in the community can track the patient down. This works really well, especially for like the homeless population, to kind of increase the compliance, and it keeps them at that nice and steady rate there. There's big particles and smaller particles, and the rate at which they dissipate is congruent for that sustained release drug. So if we can do 1 month in 3 months, and I believe as of this month, October 2021, the FDA will be soon approving a 6-month long-acting injectable. So really great news for our members of the community that have a hard time making an appointment, right? So our antipsychotics, bad. Our typical antipsychotics, as you can see, can do quite a bit of harm here. And this includes our extrapyramidal symptoms, our akathisia, or restlessness, our acute dystonia, which is that muscle contraction, especially in the neck. Our dyskinesia, which is that Parkinson-like effect, Parkinsonism, where a patient will be cogwheeling and have slow movements. And then we have our tardive dyskinesia, which includes that tic, grimacing, and tongue movements, a lot of mouth movements with tardive dyskinesia. So for akathisia, acute dystonia, and dyskinesia, oftentimes we'll use those anticholinergics like benztropine or diphenhydramine. And then for our tardive dyskinesia, medication is stopped. As of 2017, I added 3 drugs that have been approved to give for tardive dyskinesia, although I don't really see these too much. I know we didn't, in my last slide I said no, the action is to stop the drug, and that still is the first action, stop the drug. So our atypicals, the patient's going to have some sedation. They might have some QT prolongation, and that's so for our typical antipsychotics as well. And then we prolong that QT wave long and wide enough, and we're going to end up with that torsades, which is typically not congruent for life. So we have to be careful with that. The atypicals can give those extrapyramidal symptoms, just like the typicals, but the incidence is much, much lower. And then the most common interaction that you'll see with these atypicals is weight gain, and one might kind of conclude that the patient is actually getting better, that they're feeding themselves and, you know, getting three meals a day, or at least more than they were. You know, they're less sick. So part of the weight gain might be that, but they will weigh these patients frequently. Another reaction that a person can have with those atypical medications is that hyperprolactinemia, where we're gonna have lactation there. So with our typical antipsychotics, we do have a risk of having, neuroleptic malignant syndrome. Okay, so neuroleptic malignant syndrome is characterized by a high fever. That's what you're going to see kind of first and foremost. It's going to give you a clue as to what's happening there. Patient will also have some altered mental status, some rigidity, and increased myoglobin and CPK because of their rigidity there, and they'll also have some autonomic instability. So as you can see, this is an emergent situation. So our treatment options include supportive care, such as cooling the patient, dantrolene, which is used for our hyperthermic, or malignant hyperthermia, may be helpful with the neuroleptic malignant syndrome. And then we had talked about that QT prolongation, and the patient can have some pretty significant anticholinergic effects as well. For our atypical uglies, we have that clozapine, which can cause seizures, and agranulocytosis, a lack of making those white blood cells. So the patient needs to be monitored frequently while they're taking clozapine. So our mood stabilizers, right? We have our lithium, our anticonvulsants, such as valproate, our carbamazepine, and our lamotrigine. And then our atypical antipsychotics are also used as our mood stabilizers there. So what's bad about lithium? It's got that narrow therapeutic window, and it can cause that hypothyroidism, sedation, weight gain, the fine tremors, increased urination, and some dizziness. And then our anticonvulsants are not without their side effects as well, which can be the fatigue, headache, weight gain, abdominal pain, decreased libido, vision problems, and abnormal bruising. As far as the ugly with lithium, it could be it is a teratogen, which can cause some pretty significant mutations in our fetus. So lithium is contraindicated in pregnancy there, and can also precipitate a nephrogenic diabetes insipidus. Remember, it works really heavily on the kidneys there, and then we can get that lithium toxicity, which will include the altered mental status, the seizures, the nausea, vomiting, the diarrhea, and even death there. And our anticonvulsants have a potential to be hepatotoxic and can cause some thrombocytopenia. Also, women trying to get pregnant really need to add some folate when it comes to the anticonvulsants. It's not necessarily indicated. They'll use like a risk benefit for our women that are trying to get pregnant, but they do need to add some folate there. And then it can cause pancreatitis, potentially, and a rash, or Stevens-Johnson syndrome. So antidepressants, here's rules for all antidepressant. It will take about 4 to 6 weeks to start working. It can be associated with suicide, either by patients that are disappointed that the medication isn't working clear enough, or working quickly enough, or they actually have enough energy now to carry carry out an act of violence against themselves. So we have to worry about the suicide rate there, especially with our teenagers that are taking antidepressants. In the bipolar patient, an antidepressant may induce a manic episode. And then treatment is at least 1 year due to a chance of relapse. So at least 1 year. Oftentimes the shortest that a person will be on an antidepressant that is actually working is 18 to 24 months. And it's essential for our practitioners to be starting with the lowest dose or a low dose and then titrating very slowly for these people. And then trial and error is often present, and it's very individualized, even with drugs in the same class. So a person that's on one SSRI might not have any effect with that SSRI, and then you change them to another SSRI and it works wonders. So lots of trial and error can be associated with that. So serotonin syndrome can occur with all of our serotonergic medications, such as antidepressants, codeine, fentanyl, meperidine, tramadol, linezolid, which is an antibiotic, St. John's wort, tryptophan, amphetamines, cocaine, ecstasy, LSD, dextra, methorphan, lithium, bupropion, and trazodone. So a potential for serotonin syndrome. And what does this include? The tremor, diaphoresis. They're going to have lots of flushing, so they'll be nice and red. Tachycardic, hypertension, delirium, altered mental status, and even death. So our treatment for these guys is, obviously this is another emergent situation. They need to stop the medication and give ciproheptadine, which is a serotonin antagonist. So they need to stop that serotonin cascade kind of right away. So our tricyclic antidepressants, those are going to be all the ones stated below. They block reuptake of serotonin and norepinephrine. And they're also used off-label for chronic pain syndrome and enuresis. Lots of anticholinergic side effects with our tricyclic antidepressants, such as our dry mouth, blurry vision, urinary retention. So think about fluid shift and loss of fluid there. So dry mouth, urinary retention, constipation would be part of that, right? Also sedation, orthostatic hypotension, and cognitive impairment. The patient taking the tricyclic antidepressant along with our other antidepressants will have a decreased libido and weight gain. And tricyclic antidepressant we oftentimes will not give with a patient that's suicidal because it can be quite fatal in these overdoses, and it causes arrhythmias, which would be a big old problem. And QT interval prolongation for our tricyclic antidepressants as well. Our selective serotonin reuptake inhibitors, these are all the ones listed below, indicated for obsessive compulsive disorder, post-traumatic stress disorder, social phobias, generalized anxiety disorder, eating disorders, and then our depression. So the bad with these guys is GI symptoms, headache, insomnia, sexual dysfunction, so not only decreased libido, but potentially like a erectile dysfunction type situation, and increased bleeding when it's taken with warfarin. Our SNRIs, serotonin norepinephrine reuptake inhibitor, are all the ones listed below. And they have a similar side effect profile to the SSRIs. Monoamine oxidase inhibitors or MAOIs, which I've told you about, don't do, we don't use hardly at all anymore. It was the first antidepressant discovered and marketed as such. It kind of has an interesting history as far as them being used for sorry about the interruption. So our MAOIs were initially used to treat tuberculosis, and during their treatment, patients were found to be in a better mood. So it was kind of first marketed for tuberculosis treatment. Kind of interesting. So MAOIs, excuse me, are mostly bad and mostly ugly. So the bad side effects that we can get with those is a dry mouth, that nausea, diarrhea, constipation, GI effects there, headache, drowsiness, insomnia, dizziness, or lightheaded. And then ugly here causes fetal abnormalities in pregnancy, and it can cause a hypertension, coma, convulsions, or death when used with meperidine, which is Demerol. We don't use Demerol a lot anymore, but they used to use Demerol a lot for analgesia there. And then it can cause a hypertensive crisis in foods with tyramine. So you have to be really careful with the foods that the patient's eating as well. And foods that are high in tyramine are like our yeast, caffeine, wines, smoked meat, yogurt, and soy. So here's some obvious questions that a person like me might ask to test your guys' knowledge of this. What drug causes certain death when given with an MAOI? What circumstances would I give the medication benztropine or diphenhydramine? And when would I be expected to give dantrolene? What huge side effects should I monitor when starting antidepressants? My patient who is on the MAOIs is complaining of diplopia and headache. Double vision right there. Before I call the physician, what should I do? And then what diagnostic test should be performed prior to administering Haldol? And which atypical antipsychotic causes agranulocytosis? And then some potential signs and symptoms of a lithium toxicity. So there you have it. Thank you very much for participating.